Good morning. Good morning. Good morning. Good morning. Okay, we're getting a little feedback. Okay, let's try that again. Perfect. And we're ready to roll. It is now 8 o'clock, May 8th, and we are here this morning to present to you another continuing medical education topic for you. And just before we begin, as we usually do, let us say a little word of prayer. Father God in heaven, we come before you this morning, thanking you for this another day, thanking you for this another opportunity to meet here and to be stimulated with good education. We are always thankful when we can gather together as colleagues, dear Lord, and exchange information to the betterment of our patient. We pray that you be with the speaker this morning, that you bless him, and you bless us to receive the information that he's about to impart to us. This we pray in Jesus' name, amen. So thank you all for joining us for another continuing medical education event. We are so excited that you are here because we have an awesome topic for you this morning. We often don't think about ourselves. We often don't think about mental health in general. And so this morning we will be presenting to you a mental health topic entitled Self-Reflection, Assessing Your Mental Health. Just before we get started, however, there are a few things that I want to remind you of. Please ensure that your name reflects the name that you are registered at the console with. And also, please remember to fill out the feedback link. It will be posted inside the chat section. So, coming to speak to us today is Dr. KIRK CHRISTIE. Dr. CHRISTIE is an experienced consulting psychiatrist and substance misuse specialist for over 2 decades. That's a long time. He is the director of the Female Services and Addiction Services at the Sandilands Rehabilitation Center since 2016. In 2023, Dr. CHRISTIE received the Performance Excellence Program Award, also known as the PEP Award, for clinical excellence. He received his medical and specialty degrees from the University of the West Indies. He is also an alumnus of the Acadia University in Wolfville, Nova Scotia, and the College of the Bahamas, now known to us as the University of the Bahamas. Please welcome Dr. KIRK CHRISTIE.
Okay, good morning. Good morning, everyone. Can you see the screen?
Yes, we can.
All right. It's a pleasure of mine to be here this morning to talk with you for a short while. Of course, 45 minutes and even an hour will not do this topic justice, but I will get through some of the important points that I want to convey to my audience. Mental health, it's a very important topic and is increasingly becoming in vogue as we realize a lot of issues that are happening in our community, in our country with respect to disasters, also with respect to individuals and persons' mental health. And I just want to start with some quotes.
Mm-hmm. It looks really good. It looks really good.
Hold on for me. Okay, so mental health is a state of well-being in which an individual realizes his or her own abilities, can cope with the normal stresses of life, can work productively and fruitfully, and is able to make a contribution to his or her community. So mental health is not merely the absence of disease or infirmity, it's much more. William Osler, who is considered the grandfather of modern medicine, said the young doctor should look for in his lifetime early for an avocation a pastime that will take him away from patients, pills, and potions. So even William Osler knew that physicians treating patients should also have some pastimes and have some time away from the patients and prescriptions and the management of the same. I see a future where all people who have mental disorders and emotional difficulties can feel empowered to seek and receive the highest quality of mental health care that is available to them. Additionally, that we all better understand the importance of mental health to our overall health and development as a nation. Just some stats that I found from a survey, which was the Medical Protection Survey. It's referenced below, where a survey was done on general practitioners in the United Kingdom. And it was reported by way of the Royal College of Physicians that 38% of the NH staff in England had experienced work-related stress. And the report showed that less than 2/3 of trust, 65% have a staff health and well-being plan in place. And so we know in the United Kingdom, they have issues with being understaffed, and physicians working long hours in the community and also in their general medical hospitals. The Royal College of General Practitioners warned that fatigue among overworked GPs is becoming so prevalent that it could jeopardize patient safety. And of course, if you have overworked staff who are experiencing burnout and other stress disorders, which we will speak to today, they can become a safety risk for the patients whom they are managing. The college claimed that unrelenting and increasing workload pressures are pushing GPs to their limits. This was another study that I looked at involving the mental health, the incidence of mental health disorders among physicians. And in 2015, a landmark systematic review and meta-analysis collated results from 54 separate cross-sectional and longitudinal studies involving over 70,000 resident physicians from 18 countries. And what they uncovered was that by way of the clinical screens that they examined, that many physicians met the criteria for major depressive episode or clinical depression. And the rates were as high as 28.8% of those sampled in those studies. The researchers also examined the incidence of anxiety disorders among physicians, with a small number of cross-sectional studies suggesting rates of generalized anxiety disorder as high as 24%, and rates of PTSD among physicians ranging from as low as 4% to 16% of those sampled. And you can look at the study in the Lancet, and it's referenced there. Today, we're going to look at the importance of mental health among physicians. Secondly, we'll identify common mental challenges among physicians. Thirdly, to identify common mental illnesses and the management, we'll look at some of the general management principles and some tips for stress management. As I alluded to earlier in the presentation, mental health is simply not the absence of mental disorders. And we know that mental disorders are conditions that are clinically significant behavioral or psychological syndromes. Mental disorders are characterized by symptoms that are distressing and impairment in one or more important areas of functioning. And so mental health is much more. It's how we relate to our families, how we relate to our neighbors in the community, and our overall well-being. And so we have to invest in our mental health. Your mental health matters, my mental health matters, our mental health matters. And before we can take care of our patients and do our very best for our patients, we have to be whole. And so we have to be mindful that at times we may experience emotionally distressing symptoms, which warrant our investigation, our time to find out a little more what's happening with us. And the other point that I want to make is that mental health is a basic human right, and it's crucial to personal, community, and socioeconomic development. We often talk about our children, we talk about the level of violence in the country, but we as adults, as professionals, we also have to be mindful of our mental health and invest in mental health and prevent the onset of mental disorders. Some of the common psychiatric conditions affecting physicians are anxiety disorders, mentioned here, panic disorder, generalized anxiety disorder, social anxiety disorders, depressive disorders, stress disorders, such as the adjustment disorders, post-traumatic stress disorder, and for your shift workers, and especially physicians who are working late shifts on a regular basis, are prone to circadian rhythm sleep-wake disorder, which we will talk a little bit as the presentation unfolds. And of course, problematic drug use and the substance use disorders, which can become apparent in physicians who are binging and using other substances that may impair their functioning. Now, burnout is not a psychiatric disorder. It is described as a syndrome. It is listed in the ICD-11 and in terms of the medical diagnosis, but it is a syndrome of symptoms, which I will list. We'll go on to that next slide right now. So burnout is not actually a medical disorder, but it's a syndrome, and it's conceptualized as resulting from chronic workplace stress that is not successfully being managed. It is characterized by 3 dimensions: the person or physician feeling energy depletion or exhaustion. 2, there's an increased mental distance from one's job or feelings of negativism or cynicism related to one's job. In another journal that I read, it can be described as apathy, where the physician or the medical staff, they become apathetic. And there is a reduction in professional efficacy. There's a loss of resilience. And during many times of the day, junior physicians and senior physicians, they tend to work autonomously, especially if they are examining patients. They are also doing procedures on the ward. And so resilience, it helps us to overcome the job challenges, the demands of the job. And so you may have physicians losing that resiliency and going into the state. All right, how can you recognize if you are experiencing these symptoms of burnout or another of your colleagues? The symptoms that manifest early in employees who burnout include emotional exhaustion, pessimism or negativity towards everything, particularly at work, a lack of sympathy and empathy for patients and other staff, detachment from co-workers. So certainly physicians who are communicative with their colleagues now become acommunicative. They're not talking as much. They may even be on ward rounds and seem to be unfocused at what's happening on the ward rounds. There's also a sense of powerlessness or feeling as if nothing you do makes a difference, being checked out, a perception of being worse at your job than you were before. So these are the constellation of symptoms of burnout, which is now termed a syndrome, but it is listed under the ICD-11. So what is the difference between stress and burnout? So everyone deals with stress at some point in their lives. And in this presentation, we'll talk a little bit about stress, define it, and look at some of the other definitions of stress, which are known as eustress, and we'll look at distress. But it's a normal physical and psychological response to sudden dangers and long-lasting challenges. So all of us will have stress in our lives, and stress is a normal reaction to the challenges that we encounter in our social, family, occupational, religious arenas of life, and academic areas. Burnout, on the other hand, is a result of unrelenting stress. So there may be a lot of demands placed on the resident in terms of having to take care of patients, also lead clinics, Also, they have to study, prepare for examination. So this is like an unrelenting stress. So people experiencing burnout often feel mentally exhausted, disconnected, unproductive, apathetic, and inefficient at tasks. And burnout is realized in the occupational arena of life. It's not seen in other areas, such as the family, social life. And so that's why it's not a functional or psychiatric disorder, but it's under the ICD-10 diagnosis, ICD-10 and ICD-11. Now, we've all heard about anxiety. And so I just want to say to you that anxiety is normal. So there is certain times that we will be challenged and we experience symptoms of anxiety. And so this helps us to meet the challenges of our work demands, vocational, also in our social lives, to meet the demands of if you have a family, wife, children, and there's certain things that you have to do. You have to also navigate traffic in the mornings when you are en route to work. So all of this can help, cause anxiety, especially with the number of cars on the road and the traffic woes that we're experiencing now. So only when anxiety begins to interfere with social or occupational functioning is it considered abnormal. So there are instances where anxiety symptoms tend to increase in intensity, and the symptoms may lead to the person experiencing exhaustion and certain intensification of symptoms, which they may feel they're having a heart attack, and may land them in the emergency room or at the general medical clinic or community clinic. And so the common anxiety disorders are very common. And for physicians, what I've uncovered is that the common ones are the social phobia, the simple phobia, and generalized anxiety disorder in physicians. But we know that the lifetime prevalence in the general populace of any anxiety disorder is 25%. And so physicians, we are from the same populace that is at risk. And so we have to understand that the title is what we do as our jobs. We are still vulnerable to experiencing the onset of anxiety disorders if we don't have certain stress management techniques going on, coping strategies and distracting activities, and deal with the workplace stress. But we can also experience the social phobia, the generalized anxiety disorder, and to a lesser extent, the panic disorder during our course of our work life. We are not seeing physicians presenting to private practice. And so the majority of persons, especially physicians, who would have disorders such as anxiety, depression, and post-traumatic stress disorder, they're presenting in primary care setting. And so it also is very important for our physicians, GPs, and family medicine practitioners to really review the criteria of these diagnoses and to ask the appropriate questions, because sometimes it could be a misdiagnosis. What we're also seeing is that many persons are presenting with somatic complaints like headaches, backaches. So it really requires the skill of family medicine practitioners to do the screening tests, which could be the PHQ-9, the GAD-7, or Beck's depression inventory, and to dig a little deeper even about drug substance misuse. If they do a drug use disorder identification test, a DUDIT, can really uncover if the person is having problematic drug use. And we know that of those who are seeing complaining of psychiatric or psychological symptoms, 40% of those individuals are receiving minimal treatment or being undertreated. And right off the bat, we are missing 60% of persons who really need our help for psychiatric disorders. So 60% of patients we're not seeing right off the bat. So we're not seeing them at the psychiatric level. So we have to understand that persons will seek care of their primary medical doctor. So we have to continue educating our physician colleagues of the common psychiatric disorders, and that is ongoing through our training programs and certainly instances of this type of training with the CME presentations. And so some of the common disorders that I found are the post-traumatic stress disorder, and certainly persons working within the hospital, seeing deaths, witnessing trauma, you can develop symptoms of post-traumatic stress disorder. And certainly our accident and emergency physicians there who are dealing with trauma cases, just witnessing the level of trauma can cause the onset of PTSD symptoms. So we have to be mindful that physicians, we are not fully immune. Even though we are trained and we understand trauma very well, we can be impacted by trauma. Also, depression is very common among physicians because of dealing with the morbid events, mortality, deaths within the hospital. This can affect you. And certainly in our own personal lives, as we experience loss, and certainly the loss of family members, grief, there's certain instances of complex grief where persons can develop depression related to bereavement or grief disorder. And also stress. Unmanaged stress is a major precipitant of depression. But we also have problematic drug use that can bring on anxiety as well and depression. But the common ones that are affecting physicians are post-traumatic stress disorder, the generalized anxiety disorder. And with GAD, the person will experience the onset of stress, and is usually seen for 6 months and continues for 6 months, a minimum of 6 months, and you have 3 or more major life stresses, which could be in your financial arena of life, your personal and family life, and certainly workplace stress that can cause you to experience muscle tension. Also, panic attacks can happen where there's a constellation of anxiety symptoms, which are intensifying and can land you in the emergency room where you may be feeling that you're having a heart attack. OCD is seen very less in physician population. Now, social phobia physicians can also experience social phobia. And because of our training, we have to do a lot of public speaking. And so even though many physicians are good at public speaking and also talking in the front of their consultants, some physicians have problems with this, especially with anxiety and the fear of the performance situation. So social phobia is also apparent among physicians as well. Specific phobia is not so much among physicians, but in the general populace, we know that persons are plagued with having the fear of objects in certain situations. All right, so we'll continue on. So some of the anxiety symptoms from we understand are in the central nervous system: dizziness, unsteadiness, lightheadedness. In the cardiovascular system, the sensation of the heart beating rapidly. The respiratory system, short, shallow breaths. Persons have difficult breathing, sensation of difficult breathing, and even shortness of breath. Psychological, the fear of going crazy, fear of losing control, fear of dying, and the concept of depersonalization, feel as if your mind has wandered off from your physical body, and you feel as if you were living in a film, like everything is evolving around you, and you're just watching everything happening or occurring in your life. Derealization is persons who are they know of familiar places. So when they having stress symptoms, they may walk into a familiar place and it seems unfamiliar to them, and this is the derealization. And of course, in the skin, you can have the pins and needles, tingling sensation, hot flushes, chills, and sweating. These are all anxiety symptoms. And so you have to be aware that if you're experiencing such symptoms, that it could be you having anxiety. And if it's intensifying, then you have to do something in terms of dealing with it. And so we'll talk a little more as we approach the end of today's lectures on deep breathing and also progressive muscle relaxation. These are techniques that can be utilized to diminish anxiety symptoms. And so I just put in this little table. So with the GAD, always remember there's the abundance of anxiety symptoms, the progressive, the onset of worry, and progressive worrying about the future, and it tends to take over the individual, and they're really focused on this worrying and ruminating. Ruminating is just deep worrying, and it occurs when the nighttime comes after 8 p.m. Persons begin to worry about finances, worry about their job functions, all of the tasks that they have to do, and many persons experience a co-occurring muscle tension, where they're having backaches, muscle tension in their arms, their legs. Post-traumatic stress disorder, common among physicians, and it may be under-recognized because the symptoms may be sub-threshold, but just witnessing the trauma, hearing about the trauma, and certainly working among especially multi-trauma cases, mass casualty events, can also predispose physicians to developing post-traumatic stress disorder. And certainly phobias. We know that some physicians would have symptoms, stigmata of social anxiety disorder, the fear of the performance situation, and avoiding public speaking, avoiding speaking on the rounds, on the grand rounds. So these are some things that you have to be mindful of and be aware of the symptomatology. So we already spoke about social phobia, fear of social or performance situations where you're exposed to scrutiny by others. And all of us at some part of our lives, especially in our medical school training, probably experience symptoms of social phobia. The fear of behaving in a humiliating or embarrassing manner, public speaking fear, public places, and for the more medium to severe symptomatology, persons can begin to avoid going out, especially engaging in social interactions, and so they avoid. And any exposure to these situations produces anxiety. And this is a little mnemonic for the GAD. So what are the three targets of GAD? So W stands for worrying, and this is progressive worrying and fear of the future, usually onset within the past 6 months. There is a co-occurring anxiety symptoms, which could be palpitations, respiratory symptoms, pins and needles, flushing, and even threshold panic attacks, which may land the person in the ER, especially if they feel as if they're going to die. And a lot of persons who experience GAD have muscle tension, backaches, muscle fatigue, and a lot of tension in the major muscle groups. And today's presentation doesn't give us enough time to speak about the substance use disorders, but in the Lancet study, it examined a lot of physicians and found that there is a lot of problematic alcohol use among physicians, among other substances such as nicotine was another compound that was misused by physicians, and as high as 3 to 4% of those sampled. And so I would urge you to read the Lancet study, which will give you some more indications. But we know that persons who use alcohol, they use it to cope with the ongoing stress. And so alcohol can help, but we know that alcohol binging can lead to other problems such as clinical depression, and can lead to addictions where the person may develop an alcohol use disorder. So it's very important, certainly, that we have persons, because we are operating as responsible agents, we cannot be to work intoxicated or hangover. So persons who are having issues with alcohol binging or excessive consumption of nicotine products would have to seek help. It's advised that they seek help to get detoxed, and also to get some counseling and medical management if they need to medically detox and go on a drug relapse prevention program. Depression is often missed, and because a lot of even physicians and persons of the general populace present with physical somatic complaints, and we found this from numerous Caribbean studies, and certainly my time working in Jamaica here, we see even in my private practice persons presenting with somatic complaints, And when I do the 2-question screen, the PHQ 2, and I inquire about their mood, how has their mood been over the past 2 weeks, and has there been any loss in interest in normally enjoyed activities and decreased enjoyment, you would get positives. But there are some confounders with physical symptoms. So if you're having a lot of backaches, I would say, don't be dismissive of these symptoms. It could be depression. And if your mood is down for days back to back, and you're having a lot of cognitive symptoms like lack of focus, inattention, and difficulty paying attention to others, and your motivation is down, these could be signs and symptoms of major depressive episodes. So do not be dismissive of it. So this is a cartoon showing some of the symptomatology of a major depressive episode. Usually the symptoms are seen onset over the past 2 weeks, where the person has days back-to-back of depressed mood or sadness. There is a anhedonia, which is both decreased interest and decreased enjoyment from once normally enjoyed activities, and these are the major criteria. There also sleep. There could be insomnia or excessive sleeping. There also could be weight loss or weight gain, appetite disturbances, where there's decreased appetite or an increase in appetite. The person may also have psychomotor agitation or even psychomotor retardation. The energy levels, the individual is expressing that they're feeling fatigue, and if it's progressing and you're feeling even more fatigue and you're still eating well, you're drinking fluids, it could be depression. So this will clue you into that you may be going through clinical depression. And of course, the cognitive dysfunction that's related to depression, it may include the lack of focus and attention and inability to make major life decisions. And if you're having suicidal ideas and even suicidal thoughts, which you've not had during any period of your life, this could clue you into that you may be having a major depressive episode. So suicidal ideas could be present as well, or thoughts. So to make the diagnosis, 5 symptoms. One of them would have to be the major criteria, with sustained depressed mood for days back to back, or which I mentioned, 2 week onset within the past weeks to make the diagnosis of depressive. I said earlier in the presentation, developed the drug alcohol-induced mood disorder where they're being depressed. We know alcohol and drinking or binging in large quantities can lead to depression. And stress can also be a precipitant of depression. And so in my reading, with respect to burnout, they said that persons should still be aware and take action. Even though burnout is not a major psychiatric disorder, it can lead or evolve into a major depressive episode. And so persons who are experiencing burnout, I'll have some management tips for you. This should be addressed, especially if you're seeing a coworker complaining, the apathy, they just are disconnected from their colleagues. They were communicative with you, and all of a sudden now they're not communicative. These are telltale signs of burnout, which I mentioned. And of course, we all experience loss in terms of losing a loved one or losing a relationship, and this can be triggering and can lead to depression as well. And stresses in family life, social life can also evolve into an adjustment disorder, and even can be co-occurring with an anxiety symptoms and also depressed mood. So adjustment disorder is there, and that's a major stress disorder. So you have to make sure that you sort through depressed mood. It could be a number of things going on. And so you have to be mindful. If you're experiencing any of these symptoms, you have to, and so I would recommend not to be dismissive of any symptoms that you're experiencing at any period. during your work and also the social life, family life. All right, and so DSM-5 clearly elucidates criteria for making the diagnosis of major depressive disorder. And certainly in my research among physicians, major depressive disorder is common. Also, the adjustment disorders with depressed mood and also the substance-induced depression. To lesser extent, bipolar depression, if you have a already pre-existing functional disorder, bipolar disorder, you have to be cautious, especially when you're having symptoms of depression. You may be in the depressive pole of the bipolar depression, but that is not really, it doesn't have a high incidence among physicians as for those who have already pre-existing functional disorder. All right, we're going to look a little bit about stress, and this was a very good, succinct definition that in my studies that I found. Stress is defined as a disturbance in one's state of physical and psychological equilibrium brought about by a disturbance in the world around you. So all of us will experience stress. Unfortunately, until the day we expire, we will all experience stress. So stress is something not to fear, but we have to be mindful of it and know that from time to time, we will encounter the stress and certainly the stress response. And the thing is that we want to not evolve into distress. And distress is the unmanaged stress, where the person is not managing the stress, the day-to-day stress of life. They don't have any stress management. They do not employ coping strategies. And so the distress can lead you into a state where you can go on to have medical issues such as stomach ulcers, increased blood pressure and pulse rate. You can develop heart disease if you don't manage stress in an appropriate manner. But certainly on a daily basis, we may experience eustress, and this is a stress of potential gains. And this helps us to get out of bed early in the morning to deal with our children, our spouse, to navigate the roads, to deal with the daily tasks of work, and also post-work to deal with any other extracurricular activities. So eustress is something that will happen. The body may not be able to recognize the difference between eustress and distress, but we have to make an effort so that we do not experience the distress, which can lead on to major medical issues, and then can also evolve into the adjustment disorders that I mentioned before. So all of you have heard about the stress response, and it was Hans Sale, concept of stress, focus on the ways an organism could be perturbed, confused or worried, and the resulting physiological responses. Sale was responsible for the concept of the general adaptation system, aka the body's reaction to stress. Response was similar across diverse stimuli, and physiological changes represented the response to the stressor. So most of you are familiar with the hypothalamus-pituitary axis, and these are the anatomical substrates that are in control of the body's gas system, the general adaptation system. And we know the brain is, we have higher anatomical substrates, such as the hypothalamus, the hippocampus. We have the somatosensory cortices, the amygdala, and other structures within the midbrain and the prefrontal cortex, connections of the prefrontal cortex. But there's a negative and positive loop that controls the whole release of stress hormones known as cortisol and adrenaline. And there is a valve that, as we size up any challenge or negative stimuli in our environment, the adrenaline valve turns off, and there's an inhibitory effect on the brain to stop the production of these stress hormones. So negative and positive loop. And so be mindful of this HPA axis and the anatomical substrates that are involved in this general adaptation system. And for those of you who remember from probably preclinical, the general adaptation system, there's certain phases of it. with respect to the alarm reaction. And so if you were, just to give an example, if you were walking on the street and then you see a pit bull running after you, this is going to activate this GAS system. And so at a higher center, you're going to recognize this as danger, that the dog is about to attack you. And so there's a release of the adrenocorticotropin from the higher center in the pituitary. And then you're going to have stimulus in the peripheral system. And then you're going to have an outpouring of these stress hormones that have a positive response on the autonomic nervous system. And that gets you ready to take flight, to run away, and to flee the offending agent, or to fight the offending agent, whether to take up a stick or a rock and hit the dog. And so it begins with the alarm reaction. As you size up the offending agent or the noxious stimuli, then the adrenaline valve begins to turn off, because certainly if you're winning the fight with the dog, you hit the dog flees, this valve starts to turn off, and then you get back to baseline. And so the heart rate diminishes, the pulse rate, and also there is a decrease in the other symptomatology in the other organ systems. Now, there are some people who are unable to turn off the adrenaline valve, and so these are persons who may go on to develop the exhaustion, where they're having an overabundance of the anxiety, stress symptoms or anxiety symptoms, and which may land them in the emergency room. They become exhausted, they need oxygen, they need help. And so this is what we want to prevent, this intensified response. So the impact of stress, the DSM-5, the Diagnostic and Statistical Manual of Psychiatric Disorders, recognizes the existence of a group of disorders that are stress-related. These include the post-traumatic stress disorder, which I stated earlier, and the acute stress disorder. The acute stress disorder occurs within right after onset of the traumatic event up until 4 weeks. And so it is a prelude to the post-traumatic stress disorder. And so we would call it the acute stress disorder if its onset is immediately after the trauma and within the first 4 weeks. And so physicians are vulnerable, because if you are witnessing trauma, you even hearing about it, and you're dealing with trauma on a regular basis, it can evoke the symptoms of acute stress disorder. And I've mentioned them earlier: anxiety attacks, flashbacks, reliving episodes, certainly derealization. PTSD results from any life-threatening event, life-altering event. So you don't have to experience a traumatic event to have onset of PTSD. Just witnessing it and hearing about it can be triggering to post-traumatic stress disorder. So it's very, you have to be very careful with your viewing, especially with gory photos of trauma, but it's unavoidable if you're working in the emergency room. So you have to be able to deal with it and seek help if you're having stigmata of the acute stress disorder symptoms, flashback, reliving episodes, and even anxiety symptoms. As I mentioned earlier, unmanaged stress can lead to an increase in your blood pressure. Unmanaged or uncontrolled high blood pressure can lead to heart disease, kidney disease, can lead to decrease in the immune response, also increase in your dementia. And now we know that long-standing high blood pressure and diabetes can also cause dementia, vascular dementia, and can increase the neurocognitive disorder earlier than 60 years of age if you're not managing. If you have the primary medical disorders such as hypertension and diabetes and you're not managing it well, can lead to the early onset of neurocognitive disorder sooner than 60 years of age. Stress-related diseases, we know persons who develop stomach ulcers, even you can develop cancer if you're not really dealing with stress well, heart disease. And so the management of stress is very important, and it's incumbent upon all of us. And as I said earlier, the title is what we do. We are all from the same population that is at risk. And so we have to make an effort in terms of the preventative efforts of taking care of ourselves, our families. And I strongly believe that an ounce of prevention is better than a pound of cure. And we have to be mindful that many of our colleagues do have sleep disorder. And one of the common sleep disorders, which this is something that I put in, it's not really mentioned in the Lancet study and the studies that I've looked to, but I am sure that many of our physician staff have this disorder, circadian rhythm, sleep-wake disorder. And it is seen among the shift workers. And it's not just a one-off overtime shift that a physician takes, but if you're working the regular nighttime shift, and the DSM-5 talks about after the 8 p.m., the 8 a.m. to 6 p.m. shift, and you're working it on a regular basis, this may lead to this problem with the circadian rhythm, sleep-wake disorder, and it's persistent or recurrent pattern of sleep disruption that is primarily due to an alteration of the circadian system or to a misalignment between the endogenous circadian rhythm and the sleep-wake schedule required by an individual's physical environment or social or professional schedule. And the sleep disorder leads to excessive sleepiness or insomnia or both. Sleep disturbance causes clinically significant distress or impairment in social, occupational, and other areas of functioning. And so, in simple terms, it's the insomnia during the major sleep period and or excessive sleepiness, including inadvertent sleep during the major wake period associated with a shift work schedule. And so it's very important that shift workers at some point go back to the normal shift so that they may not perpetuate the circadian rhythm sleep-wake disorder. So they really should have the period of the late night shifts, but it should be alternated with regular issues. So this sleep disorder is not perpetuated and they could end up with insomnia. And of course, if you have increased wakefulness, more than 13 hours of wakefulness, you can go on to psychosis, becoming psychotic. So the body needs to rest, the brain needs to rest to clear the metabolites and end products in the brain, and also to consolidate memory and reset brain functioning. So sleep is very important. Physicians and also our ancillary colleagues working in the ancillary service. I would be remiss if I were not to speak on natural disasters. And certainly not to be a Cassandra or the bearer of bad news, but we did experience the pandemic, even though it feels like some time ago, and it brought a lot of psychological and behavioral responses. And I'm sure some of us are still reeling from the after effects of the COVID-19 pandemic, certainly Hurricane Dorian and other catastrophic storms such as Hurricane Matthew, Hurricane Irma, which affected the Bahamas. And we are now almost back in the meteorological season, the hurricane season. So we have to be mindful of disasters and how it affects us. And while many of us were resilient during the COVID-19 pandemic, many of us experienced the emotionally distressing symptoms, reactions such as insomnia, decreased sense of safety. This affected our mood, and we were distracted a lot. And certainly during the COVID-19 pandemic, with all of the prohibition and restrictions, and certainly not knowing whether or not you could go outside, especially during the second and third and fourth quarter of 2020 and early into 2021. This caused a lot of anxiety. And certainly there was a lot of fear mongering. There was a lot of salacious stories, media, a lot of news, sensationalized news. And so this did have an impact on us, all of us. And some health risk factors which are seen after a disaster include the problematic drug use, such as alcohol and nicotine products. Certainly the inability to get medications, especially with shipping, the shipping lanes closed. There were some medications we could not receive. Also, the families in distress dealing with certainly the fear and also the inability to move. There were many restrictions on the roadway. Of course, physicians were able to maneuver without any major obstructions, but there were times that we could not move, especially when there was a full lockdown. Only the physicians who were working in the hospital could leave at a certain time, and there also were restrictions on travel as well. There was, with any disaster, there are certainly, because of crowding, persons staying home a lot. And in the case of the COVID-19 pandemic, there were a lot of persons restricted to home. And so we saw intimate partner violence increasing. Also, there were issues with battery going on, and assaults in the home. And so this disrupted all of our lives, and certainly more of the persons in the community. But it's mindful to understand that the common psychiatric disorders related to natural disasters include anxiety disorders, major depressive disorder, post-traumatic stress disorder, and certainly grief. We know we had losses among physician staff and also nursing staff and the para-allied health. So this causes grief. Now, grief is a normal healing, normal reaction to loss, but there are instances where persons can develop complex grief, where they develop a co-occurring major depressive episode, and they need talk therapy in addition to medication management. So these are the common psychological and behavioral responses that we need to be mindful of. And is not if a pandemic will occur in the future, is when. So we have to be ready, and as part of our development plan for the next pandemic, we have to make sure that we're ready. We have all of the resources, and there are times that mental health is left at the back, at the rear. We need mental health right up there when we're talking about managing disasters. We are usually an afterthought, and so I would really propose to the powers that be to include mental health professionals when we're dealing with disaster response. And we have been, in terms of the meteorological disasters, we play a role in terms of the assessments in the Family Island communities when they are affected by the hurricanes. And we also do the visitation for psychological first aid, and also review of our chronic our patients with chronic psychiatric disorders in the Family Island. We also have ongoing visitation to our Family Islands. We have about 13 islands covered by way of the Mental Health Global Action Program. We have the annual Family Island mental health visitations. So this is just a cartoon showing some of the natural disasters. In our case for the Bahamas, we experienced the meteorological, and certainly biological would be the pandemic that would fall under, even though there's another category for natural disasters. And we also have to be mindful of the increasing heat under the climatological disasters. So we are now experiencing heat waves. And so it's predicted that this summer is going to be very hot. And we know that the heat can precipitate the onset and relapse of medical disorders, and also can cause the onset and relapse of psychiatric disorders. So we have to ensure that our patients with chronic medical disorders understand what dehydration is, what heat stroke means. So we have to do more in terms of psychoeducation of our patients regarding heat. And this is another cartoon just showing some of the things I mentioned with the post-disaster response. And we see, again, under mental illnesses, the PTSD, complex grief, and certainly persons with pre-existing psychiatric disorders can go into relapse states. And certainly the problematic drug use during this time of the pandemic. We should always remember that in a disaster, the size of the psychological footprint greatly exceeds the size of the medical footprint. And so this brings me back to having the mental health services available. And we should always have mental health professionals when we're dealing with disasters and input. from on committees. All right, so we're coming to the end, and so I will just tell you a little bit about how one can access help. And as we always say to our patients, and when we talk to medical students, there could be a medical cause of your symptoms. So if you're experiencing heightened anxiety, if you're having fatigue, it's best to get a medical evaluation. And so I would implore all of you to also make sure you have your physical annual, and certainly be guided by your primary medical practitioner, but always get a medical checkup, because sometimes you're feeling well and things could be going on. It's an interplay between nature and nurture, and certainly genetics and certainly environment, but always stay checking in terms of having a primary medical doctor evaluating you. And certainly a lot of our colleagues can manage major depression, so our hats off to our family medicine practitioners, and they've been involved with previous training in the Mental Health Global Action Program. Sandilands Rehabilitation Center has been pushing for the integration of psychiatric services into community health. We have a good relationship with our residents in family medicine and emergency room medicine who rotate through Sandilands Rehabilitation Center. And so the management of psychiatric disorder is not a Sandilands physician issue. It's all of our issues. So all of us have to learn and increase our awareness of the commonly diagnosed psychiatric disorders, because primary medical practitioners are the ones who will see persons first. They rarely come first to see a psychologist or a psychiatrist. So you all, in one sense, are the gatekeepers in terms of being able to tell if there's a complexity, to consult with the psychologist and or psychiatrist for further management if you're seeing some complexities with the patient. So we employ a biopsychosocial spiritual approach to management of anxiety disorders, mood disorders, substance use disorders. So I've added spiritual to say that we are mindful that the spirituality is very important among persons. And so whatever you believe, is good to have spiritual awareness. And we know that this can help you in addition to the medication management, the psychological intervention such as talk therapy. But we know that leaning on a higher power is very important. Engaging in your church involvement or other religious involvement can help you. And so the whole management of psychiatric disorders, if you're referred, is a person-focused, collaborative care model that we follow. So we have talk therapy. I work in an office that talk therapists are present. We do comprehensive screening and evaluation, and we really look at holistic health now in terms of nutritional health, exercise, and also mindfulness. So all of these things can help you. And so if you are experiencing any emotionally distressing symptoms, do not be dismissive of these symptoms. Listen to others around you, listen to your spouse, to your mentor, act upon it, and follow up with your primary medical doctor. So, and this goes, if you're seeing any of your colleagues having difficulties, speak with them, and listen to them without passing any judgment. It's called empathic listening. And if they are on the fence about seeking help, offer to go with them to their primary medical doctor. Sometimes the support would really go far away in helping your colleague. And some of the stress management techniques, we don't have time to get into all of it, but what I teach is a little bit about positive self-talking, where persons begin to make positive statements on a daily basis. Certainly, gratitude, making statements about being grateful can help you to deal with the stress of life. And all of us will experience stress, but if we are grateful, if we make statements in the morning, I'm grateful for my life, for my family, I'm grateful that I have the ability to help others and be altruistic. These will help us to regain sense of control. And so some of the relaxation tips is what I tell persons to have a stress reliever, especially at work. If you're being stressed out, if you're feeling stressed, sometimes it's good, if you're not on rounds, take a little break. Go to the cafeteria or go to the doctor's lounge, have a few minutes, and then get back to your skills. So take a break And this may help you as you reset your attitude, your motivation level can be reset. And so this works very well. And certainly deep breathing, if you're feeling stressed, a few deep breaths in and out. It may be difficult at work to do that, but especially if you're at home and you're experiencing undesirable stress, there's something called the 4-second box breathing technique. And it's self-explanatory. You can go online and just view on YouTube, and it will show you how to do it. And it's simple, controlled breathing over 4 seconds. And for those persons who have ongoing stress, sometimes journaling can help you. Writing down your daily stresses can help you to deal with any of them and to really question the negative thoughts that you're having on a daily basis. Is this something that I really need to be stressed out about? Or is this realistic or not realistic? Why am I so distressed about it? So journaling can help you. And certainly if you're having problems and these strategies are not helping you, then you could see a talk therapist. So talk therapists available in the community privately and also publicly through the Community Counseling and Assessment Center. We also have therapists working in the community and private practice that you can speak with, and they will help you with mindfulness. And mindfulness is just using meditation and also tying it to yoga, certain yoga poses that can help you to diminish stress. And so mindfulness is also taught online, and you could also read books on mindfulness. Is very important, and it's very productive in persons who utilize the mindfulness techniques. Your mental health matters, my mental health matters, our mental health matters. And so just continuing on, find connectedness, have a circle of friends, have a mentor in your life, have your family. If there's someone in your family whom you are communicative with, talk with that person when you're encountering any emotional distress symptoms. Seek advice and reassurance. Strive to maintain a minimum of 7 to 8 hours of sleep. Of course, the emphasis of nutritional health, we are talking about getting the vegetables and herbs and diminishing sugar in the diet and also fatty foods. And getting 3 meals a day with snacks in between, especially persons who are on call. It may be worth your while to have some granola bars or something, some snacks, some nutritious snacks in between that can help you, especially during the late night shifts. And ensure daily exercise of about 150 minutes a week. If you can get to one session of 30 minutes, that's a start. Start somewhere. And limit the alcohol intake and misuse of other substances. And we know that alcohol binging can lead to depression, clinical depression. And certainly the use of nicotine products, we know is very dangerous, especially I know a lot of younger persons are engaging in vaping. It's not a very good thing to do, even though it is being suggested that it is an appropriate replacement activity for cigarette smoking. But of course, due to the chemical lung injury and EVALI, e-cigarette and vaping associated lung injury, it is ill-advised for persons to have any short-term use of vaping devices and also long-term, intermediate and long-term use of vaping devices. So EVALI is well elucidated. You can read it online or at the National Institute of Drug Abuse. Just type in EVALI. Limit the intake of caffeinated products, certainly meditation, which I spoke to, quiet medication, relaxation, reflection, and prayer. We know that persons who attend church and pray regularly, their blood pressures are low and pulse rate are low, and they are in good medical health. And so we know church attendance also is protective. And so I would advise that you look at this closely and find time to indulge. And know your limitations. You're not perfect. Add structure to your life. Keep appointments. Keep home organized. Keys in the same place. Sometimes this could be problematic. You're home, and in the morning you're trying to find the car keys or the house keys. So make sure put all of your keys in a bowl somewhere near the front entry door, so you're not in the morning delayed for work. And keep yourself financially secure. Live below your means. Put more in the savings account. Don't overexpend or overextend yourself, especially when on vacation and during breaks. Learn the value of judicious complaining. Talk your way through a problem. Ventilate to a trusted friend or confidant. Learn how to let go of worries. And this is where journaling comes in. And I spoke about it. Journaling is very important and it can help you. And know that you're not perfect and don't sweat the small stuff. Okay. If you don't get something done in a day, then it could be done tomorrow. But certainly lean on your colleagues if you are behind in drawing blood, or there's a procedure you didn't get a chance to do. Speak with your colleague and they may possibly be able to assist you, especially at work. So you utilize the skill and the altruism of other friends and work colleagues. So some of the barriers to seeking treatment for a physician are similar to persons in the general populace. There are physicians who may be ashamed and face shame if they are saying that they want to seek psychiatric care. And this may be apparent when they may be referred from their primary medical doctor to see a psychiatrist. So shame is one of the barriers. Fear, persons are afraid because they don't want to, get another diagnosis or be diagnosed. And certainly physicians, we can be terrible patients because we're so we're familiar with psychological functional disorders, and we don't want to be labeled as being the depressed person or anxious person. So there is some fear of seeing a psychiatrist or a psychologist. There may even be denial, or I don't have a problem, there's nothing wrong with me, you have the problem, there's no problem with me. So denial is an immature self-defense mechanism that persons use to deny that they have a problem and to decrease the anxiety, evoking impulses related to being labeled. And certainly physicians may perceive there's a lack of confidentiality if they go and see a psychiatrist or a psychologist, and even a lack of anonymity. We know that physicians would prefer private practice because if you go to community counseling and assessment center, you're in a waiting room where everybody sees you. There may be some persons who recognize you. So certainly anonymity is better maintained in the private practice where you go to office by appointment, not very many people in the wait room. So we have to be mindful of this, that anonymity is very important when it comes to seeking help for mental health issues or emotionally distressing symptoms. But certainly your primary medical doctor can start the process, and they are well trained in terms of diagnosing and managing non-complex psychiatric disorders. And this is my final slide for today. And so physicians are vulnerable to burnout, depressive disorders, generalized anxiety disorders, adjustment disorders, PTSD, and problematic substance usage. Barriers to treatment include fear, shame, perceived lack of confidentiality, lack of anonymity. Prevention measures include self-care, casual leave, and vacation leave, stress management and coping strategies, positive self-talking, positive affirmation, distracting activities. Treatment is available to physicians and includes medication management and talk therapy. And some of the talk therapy modalities include cognitive behavioral therapy, interpersonal therapy, supportive therapy. Your primary medical physician is the person that is the first contact. And it is advised that you seek a medical evaluation, speak with your physician about any emotionally distressing symptoms. And if you need more intensive talk therapy, your primary medical practitioner will refer you to see a psychologist and or a psychiatrist, and we are available in the community. And if you have any need for information, you could visit my website, and also you can call me, you can email me directly, and I will answer any questions that you may have. There's some resources here at this website at Stop GG, very good resources for self-help and self-care. Thank you all for today. It has been a pleasure of mine talking with you today, and I'll entertain any questions that you may have right now.
Thank you so much. Thank you so much.
Yes, you're welcome.
Dr. CHRISTIE. That was definitely a very, very, very informative, comprehensive talk that you gave, filled with a whole lot of useful information And I am most certainly that we can all benefit from the advice that you give. We know that as physician, as you said, there are many barriers that stand in our way of seeking mental health in particular. And I sincerely hope that after this talk that we all would feel a little bit more comfortable in seeking the necessary help that we need. We are exposed to so much stress on a daily basis, and it's important for us to have an avenue to release and to know that it's okay. And I love the thing that you said. You talked about our mental health matters. And I think that's something that we need to reiterate often among ourselves. Our mental health matters. We're not immune. We're not immune at all. So let's jump over to the chat and see what we have here. Okay, Dr. Singhui is saying, great overview and advice. Arlene Ching is saying, great presentation and very informative. Absolutely. Do we have any questions for Dr. Christie? While you may think about your questions or your comments, we recognize the nurses joining in. Thank you for joining in to our talk this morning. I know that the information is also very beneficial to you as well, as Dr. Christie mentioned throughout. It's all of us, physician, nurses, allied health. It's information that's useful across the board. And just to plug in while you think of your questions and or comments, please ensure that your name does reflect the name as it should on your CME certificates. So for those who logged in with iPhones or just a surname or just a first name, kindly quickly change it to the full name. And the link is also present in the chat. Please fill out the feedback link. That would be greatly appreciated.
I can also forward the presentation to you. If anyone wants a presentation, I can forward to them as well. So
yes, please. That'll be greatly appreciated. So if there are no more questions or comments, thank you for joining us. A special thank you to Dr. Christie, and we hope to have you back soon so that you can give us even more useful information.
Yes. Thank you. The pleasure is all mine.
Thank you. We have another great presentation. Thanks coming in from Dr. Dominic Johnson as well. So my dear colleagues, as you would have completed this wonderful lecture, you have just leveled up in your knowledge. And I will see you at our next CME. Have a great day.